Hello students, so now we will discuss about hypolipidemic drugs. So in this section, first we will discuss the four major classes of hypolipidemic drug, that is statins, resins, fibrates, and one vitamin which is used as a hypolipidemic drug, that is niacin or vitamin B3. Then we will discuss the management of dyslipidemias, and lastly we will discuss various new updates and the new drugs which have been approved as a hypolipidemic drugs. So what do you mean by the word hypolipidemics? As the name tells you, hypo means they reduce, lipidemic means they reduce blood lipid levels. That is why these drugs are given in the treatment of dyslipidemia. Now, dyslipidemia means when there is abnormal, dys means abnormal, increase in blood lipid levels. Now, to understand it in a more simple way, remember we have two types of bad lipids. The first is cholesterol. Remember, cholesterol is a cyclical lipid. It has cyclical rings. And another lipid is triglyceride. Triglyceride is a straight chain lipid. Now, these two lipids, when increased in the body, remember they are very bad for us. If cholesterol levels are increased, cholesterol deposits below the blood vessels, below the endothelial cells of blood vessel, which leads to narrowing of blood vessels. This is known as atherosclerosis. So, increase in cholesterol level leads to atherosclerosis, narrowing of blood vessel. So, if coronary artery becomes narrow, blood supply to the heart is reduced, it can lead to MI, myocardial infarction. And if this atherosclerosis occurs in cerebral arteries in brain, it can lead to stroke. And in fact, at today's time, the most common cause of MI and stroke is atherosclerosis. Now, if cholesterol is increased, we know what happens. Can you think and decide if triglyceride levels are increased, why it is bad for us? Remember, if triglyceride levels are increased, they damage pancreas. So, hypertriglyceridemia leads to acute pancreatitis. So, don't you think that is why cholesterol and triglyceride must be reduced in the blood? That is why hypolipidemic drugs are given in the treatment of MI, stroke and acute pancreatitis. Now, before starting with the drugs, now let's learn this in a more interactive way. Just imagine you have eaten a cheese burst pizza which contains lot of triglyceride and cholesterol. They will come to your stomach like cholesterol and triglyceride. From stomach and intestine, they will enter into lymph. And in lymph, we discussed these lipids, they are transported with the help of chylomicrons. So, chylomicrons, they will transport this lipids through lymph, and through lymph, all chylomicron will go to the liver. Now, liver into the blood will secrete VLDL, very low density lipoprotein. Now, this VLDL will be converted into IDL and LDL with the help of lipoprotein lipase enzyme, which converts VLDL into IDL and then LDL, because lipoprotein lipase removes triglyceride. Now, if our body cells require cholesterol, they contain LDL receptors, and LDL receptors donate cholesterol to the body cells. Now, these are bad lipids. Hence, we have a good lipid also, HDL, high density lipoprotein. It removes this cholesterol from the body cells. Hence, it reduces the risk of atherosclerosis. Now, this HDL, with the help of CETP, cholesterol ester transfer protein, transfers this cholesterol to LDL, and this LDL is taken up or removed by the liver. So, suppose you have eaten cholesterol and triglyceride rich pizza. So, this dietary lipids, they are absorbed from intestine into lymph. And in lymph, they are transported with the help of a lipoprotein. Lipoprotein means they transport, these are protein molecule which transport lipid. So dietary lipids, they are transported with the help of chylomicron, and chylomicron hence contains both cholesterol as well as triglyceride. So these chylomicrons, they go to the liver, and the function of chylomicron is over now. Now from liver we know blood arises, and blood is the main transport media of our body. So into the blood, liver secretes VLDL, and VLDL transports both cholesterol as well as triglycerides. Now this VLDL further gets converted into IDL, that is intermediate density lipoprotein. VLDL will be very low density lipoprotein, and IDL will be converted into LDL, which is low density lipoprotein. Now IDL contains more of cholesterol, less of triglyceride, and LDL contains cholesterol only. So one question arises, who is removing this triglyceride from the blood? Remember, on our blood vessel, endothelial cells of our blood vessel, on their surface there is an enzyme. On these endothelial cells, we have an enzyme known as LPL enzyme. LPL stands for lipoprotein lipase enzyme, and the function of lipoprotein lipase enzyme is to remove triglyceride from the blood, which converts VLDL into IDL, IDL into LDL, and hence LDL only contains cholesterol. Now, one question arises, sir, if our body cells require cholesterol, then who will donate cholesterol? Sir, cholesterol is required for cell membrane synthesis, hormone synthesis. So remember, each and every cell of our body, they contain LDL receptors. And LDL is the main species that will donate cholesterol to the body cells. And remember one point, that these lipids, VLDL, IDL and LDL, they are very bad lipids. If their level is high in blood, more in blood, they will donate extra cholesterol, they will donate extra triglyceride to the body cells, which can lead to atherosclerosis and acute pancreatitis. So these are very bad lipids. Do we have any good lipid? Yes, we have a good lipid. That good lipid is HDL. So HDL is good because the function of HDL is to remove cholesterol from the body cells. So if the levels of HDL are more, can we say there is less risk of deposition of cholesterol in blood vessels or any other organ? So increased HDL is good, it reduces the risk of atherosclerosis because it removes cholesterol. Now what is the function where this HDL will take cholesterol now? HDL donates this cholesterol back to the liver. So remember, this is the normal physiology. So if you have understood this normal physiology, now let's start with hypolipidemic drugs. So basically, if we see the list, we have four main classes of hypolipidemic drug. The first is statins. Then we have resins. After resins, we will discuss fibrates, and which vitamin is used as a hypolipidemic drug? That is niacin or vitamin B3. So after we are done with these four main classes of hypolipidemic drug, we will discuss various new drugs which have been approved, and they are also very important for our exam. So let's start with the first drug. That is a very famous class of drug, that is statins. So how do statins act? Remember, inside our liver, cholesterol synthesis happens. So cholesterol synthesis happens inside the liver. And statins inside the liver, they inhibit this cholesterol synthesis. So can we write like this? That statins inhibit de novo means inside the organ like liver, inhibit cholesterol synthesis in liver. Now, how statins inhibit cholesterol synthesis in liver? This is a very important point. Statins are competitive inhibitor of one enzyme. So, statins are competitive inhibitor of an enzyme known as HMG-CoA reductase enzyme in liver. Now, what is the function of HMG-CoA reductase? The function is it converts HMG-CoA into mevalonate. And this mevalonate, which is normally produced through various steps, it makes cholesterol. So, HMG-CoA into mevalonate, this step is the rate limiting step of cholesterol synthesis, which is carried out by HMG-CoA reductase enzyme, and statins inhibit the rate limiting step of cholesterol synthesis. So, can we say that inside the liver, cholesterol synthesis is blocked? Now, the liver will say, sir, I need cholesterol at any cost because I have to do various functions of the body. Liver itself cannot synthesize cholesterol. So, what liver will try to do? Liver will take cholesterol from the blood. And we just discussed that which molecule donates cholesterol to each and every body cell? Yes, that is LDL, because LDL contains cholesterol. So, what will happen slowly and slowly on the liver cells, the LDL receptors will increase because liver will now try to take LDL from the blood, which will lead to LDL uptake from the blood. So, in simple word, if you inhibit cholesterol synthesis in liver, LDL receptors on liver will increase and liver will now take LDL cholesterol from the blood. Don't you think it will reduce blood lipid levels or blood LDL level, which is a good thing. So, this is how statins, they work. So, just imagine in a more simplified manner that when we give statins, they reduce cholesterol synthesis in liver, which will increase the LDL receptors on liver. And if there is more amount of LDL receptors on liver, they will take LDL from the blood, they will reduce blood LDL levels. So this is how statins, they work. So overall, what is the effect of statins on blood lipid profile? So what about blood LDL level? Statins, they reduce blood LDL level. And among all hypolipidemic drug, maximum reduction in blood lipid level or LDL level is by statins. And we know that LDL contains cholesterol. That is why statins are the drug of choice for hypercholesteremia, because LDL contains cholesterol. Do statin have effect on other lipoproteins? The answer is yes. Statins mildly increase HDL level, which is a good thing. And statins also decrease blood triglyceride level, but this is not maximum. Maximum effect of statin comes on blood LDL level. Now, the first two effects of statin, that is reduction in blood LDL level and increase in HDL level. Remember, these two effects are dose-dependent effect of statins. That means, if you give higher dose, there will be more reduction in blood LDL level and increase in HDL level. But a decrease in triglyceride level is dose-independent effect of statin. It does not depend upon the dose. So, keeping this thing in mind, let's see what are the drugs we have in statins. So, the first two statin which we made were lovastatin and pravastatin. Then we made other statins like fluvastatin, simvastatin, atorvastatin, rosuvastatin, and pitavastatin. So we can remember LPF SARP. So let's see how much blood lipid level they can reduce. So when we want to reduce blood lipid level by 30 to 50%, we call it as low intensity statin therapy. Low intensity means when we just want to reduce 30 to 50% LDL level. So in low intensity statin, we can give all statin. But what is their dose? So the dose of Lova, Prava and Fluvastatin is 40 mg. Simvastatin, half it, 20 mg. Atorvastatin, make it further half, 10 mg. Rosuvastatin 5 mg, and lastly pitavastatin 2 mg. So can you tell me which statin requires least dose? That is pitavastatin. Hence can we say pitavastatin is the most potent statin? The drug which require less dose are more potent. Now another type of statin therapy is known as high intensity statin therapy. High intensity means when we want to reduce blood LDL level by more than 50%. And in this case, only two statins are there which can reduce blood LDL level by more than 50%. So let's see which statin. So the statin which can reduce is only and only atorvastatin and rosuvastatin. Only two statins can reduce blood LDL level by more than 50%. So what is the dose? The dose of atorvastatin is 80 mg and 40 mg, which is their maximum dose. And in maximum dose or high dose, they can reduce more LDL level. So this type of therapy is known as high intensity statin therapy. So where it will be used, that I am going to tell you. But can you tell me two statins which are most effective are Atorva and Rosuva? Keeping this thing in mind, let's answer certain question. So can you tell me which statin is most potent? Most potent means which require least dose. That is pitavastatin. Now which two statins are most effective? Most efficacious, which can reduce maximum LDL level? Yes, we know the answer, rosuvastatin. And if rosuva is not given in the option, we will go by atorvastatin. So one question will be coming in your mind, sir, why they are most effective? Why other are not most effective? The reason is very simple, because these statins are the longest acting statin. They keep on reducing blood lipid level or LDL level. So again, the longest acting statin is rosuvastatin and atorvastatin. So you must have seen, most commonly as a doctor, we are prescribing these two statins only. Now, what is the route of administration of all statins? All statins can be given orally. All are given orally. But there are two statins which can be given IV during an emergency of MI and stroke. Again, the answer is Rosuva and atorvastatin. Now, all statins, they are taken at night time. Night time means we tell our patient to take statin before sleeping. The reason is very simple, because when you sleep and around 2 AM or 3 AM in the morning when we are sleeping, maximum cholesterol synthesis occurs during sleep. So night time, maximum cholesterol synthesis occur when we are sleeping. So don't you think giving statin just before sleep will have maximum effect on synthesis of cholesterol? Yes, but there are two statins which can be taken any time during the day. Again, the answer is rosuvastatin and atorvastatin. So these two statins, they can be taken any time. The reason is very simple, because these two statins are the longest acting statin. That is why you can tell your patient to take at any time. Now let's talk about their pharmacokinetic. All statins in our body, they are degraded or metabolized by CYP3A4 enzyme. So they are degraded by CYP3A4 enzyme. So like simvastatin, atorvastatin. Now don't you think we have already discussed there are certain drugs which are CYP enzyme inhibitors. So if we give a drug which is a CYP enzyme inhibitor, don't you think these drugs will inhibit degradation of statins in the body? And if statins are not degraded in the body, their toxicity might come. So all statins, they show lot of drug interaction, and here comes a question, except which one? Which statins are not degraded by CYP3A4 enzyme? The first is again rosuvastatin, and the second one is pravastatin. Rosuvastatin and pravastatin, they are not metabolized by any CYP enzyme. So if I'll ask you that which statin will have least drug interaction, it is the most effective one and it can be given in high intensity statin therapy. Is it atorva or is it rosuvastatin? Yes, the answer is rosuvastatin. That is why at today's time we are prescribing rosuvastatin to most of our patients. There is one more statin we will write is fluvastatin. Fluvastatin is not metabolized by CYP3A4, it is rather metabolized by CYP2C9 enzyme. But we have to remember rosua and pravastatin. Now let's talk about where statins are used. We know that statins, they reduce blood LDL level maximum among all drugs. LDL contains cholesterol. Hence, statins are the drug of choice for hypercholesteremia. When the blood cholesterol level is very high, the drug of choice is statin. So one question is, sir, what causes hypercholesteremia? So let's see the causes of hypercholesteremia. The most common cause is metabolic syndrome. Metabolic syndrome means a person is obese, having sedentary lifestyle, means no exercise, eating lot of pizza and high calorie diet can lead to hypercholesteremia. So it's a lifestyle disease. It is the most common cause of hypercholesteremia. Other causes are nephrotic syndrome. Third cause is drug induced. Now, which drug can increase blood cholesterol level? First, you will write is loop and thiazide diuretics. Second is beta blockers. And lastly, corticosteroids. Corticosteroid, or you can write Cushing syndrome, when a person takes long-term intake of corticosteroid can lead to hypercholesteremia. Any cause of hypercholesteremia, drug of choice is statins. Now, we just discussed a word known as high intensity statin therapy. So, let's recall, what do you mean by high intensity statin therapy? When we want to reduce blood LDL level by more than 50%, then it is known as high intensity statin therapy, and two statins are approved for this condition. One is atorvastatin in the dose of 80 mg or rosuvastatin in the dose of 40 mg. So one question arises, when we want to reduce so much blood LDL level, high intensity statin therapy is an indication if the patient is having MI and stroke. Remember, during MI and stroke, we give injections of atorvastatin 80 mg or rosuvastatin. They can reduce the risk of sudden death by inhibiting atherosclerosis by more than 40%. Second point, when blood LDL level is more than 190 milligram per deciliter. Sir, why? Because our goal of LDL level is always less than 100. We have to maintain LDL less than 100. So don't you think if it is more than 190, we have to reduce by at least more than 50%? And lastly, if the patient is having raised LDL, it could be any LDL level, plus the patient is having diabetes mellitus. Raised LDL, any raised LDL with diabetes mellitus, give highest dose of statin. The reason is both diabetes and LDL, they contribute to atherosclerosis. So these are the three indications of high intensity statin therapy, and there are only two statins which are used. Now let's talk about a very beautiful property of statins, which is known as pleiotropic effect of statin. Now pleo means many, tropic means beneficial effect. Remember, statins just don't reduce blood LDL level or cholesterol level. Statins have many other beneficial effects in the body. Because this mevalonate pathway of cholesterol synthesis, it is a very harmful pathway. Remember what happens basically if there is excessive activation or excessive atherosclerosis. Atherosclerosis is not just the physical deposition of cholesterol. No, atherosclerosis is an inflammatory condition. Here continuously inflammation happens. And because of inflammation, the endothelial cells of blood vessel can get damaged and suddenly platelets will come and completely block the blood vessel. Now statins, apart from reducing blood LDL level, statins have direct anti-atherosclerotic effect. They inhibit this inflammation of atherosclerosis. Now you know that during inflammation, suddenly endothelial cells will get damaged and platelets will come and they will block the blood vessel. Statins have anti-platelet effect as well. Statins also inhibit fibrin deposition, or they have anticoagulant effect. Now during inflammation, don't you think cells will die? Because the cells will die, DNA will get damaged, and DNA purines, they are converted into uric acid. So in atherosclerosis, uric acid level is also increased. Statins, they also reduce blood uric acid level. So these are the many other beneficial effects of statin. So you can write how we check that they are reducing inflammation. It has been seen that statins, they reduce the level of CRP, C-reactive protein, which is a marker of inflammation. Now let's talk about what are the adverse effects of statins. Remember, statins are very safe drug. The side effects which are generally seen are very less common side effects. The side effects or adverse effects are very less common. The two main adverse effects of statin is, first is hepatotoxicity. They can damage liver, and it is the most common side effect of statin. So in question, you might find raised AST level, ALT levels. But the characteristic side effect of statin is myopathy. Remember, they damage muscles. Now, why they damage muscles? Because they reduce the production of coenzyme A. How we can remember? HMG CoA reductase, that enzyme is required for production of coenzyme A. This enzyme is required for normal functioning of muscles. Statins reduce their production and muscles will become damaged. So how the patient will present to you? So if the patient is having simply myopathy, patient will be having muscle pain. But sometimes this myopathy becomes so severe that these muscles, they become damaged or degenerated. So this myopathy sometimes can lead to a very dangerous side effect, that is rhabdomyolysis. Now if rhabdomyolysis happens, this is dangerous, which is degeneration or damage of skeletal muscle. So if muscles will become damaged, don't you think the substances which is present inside the muscles will come into the blood? So let's see the features of rhabdomyolysis. So inside the muscle we have an enzyme, CPK enzyme, creatine phosphokinase enzyme, that will be raised in blood. Similarly, inside the muscle we have potassium. Potassium will enter into the blood. It can lead to hyperkalemia. And inside the muscle we have myoglobin. So this myoglobin will come into the blood. Now this myoglobin will be excreted in urine and the patient will have myoglobinuria. This is a very characteristic feature of rhabdomyolysis. So in rhabdomyolysis, when myoglobinuria happens, the characteristic finding you will get is cola color urine, which is a hint. And this myoglobin, while passing out through kidney, damages kidney. It can lead to acute renal failure and patient may die. So now you have understood the features of rhabdomyolysis which can occur with statin. So one question comes in our mind, sir, what are the factors which can increase the risk of myopathy or rhabdomyolysis with statin? So those factors are when you are giving high dose of statin. So myopathy is more commonly seen in high intensity statins, and we know high dose of statins are atorva and rosuvastatin. When given in high dose, more risk of muscle damage. It is more seen in alcoholics. It is more commonly seen with CYP enzyme inhibitors, because CYP enzyme inhibitor inhibit the degradation of statin. Statin level increases, more risk of muscle damage. So various names of CYP enzyme inhibitor we can remember with the help of a mnemonic: Coke. C for cimetidine, which is an antihistaminic drug. Omeprazole, proton pump inhibitor. Ketoconazole, erythromycin. Now one drug needs special mention. That is one drug for HIV, which is also a CYP inhibitor, that is ritonavir. Okay, ritonavir. Now a recent question, risk of this myopathy is more common in males or females? It is more common in females. And lastly, when statins are combined with other hypolipidemic drugs, the risk of myopathy increases. So we can write two other hypolipidemic drugs. One is fibrates. And in fibrates, you will get an option of gemfibrozil. So you can identify some fibro word is coming. And lastly, niacin, because other hypolipidemic drugs can also cause myopathy. Now, what are the contraindications of statin? Statins are absolutely contraindicated in pregnancy. So we never give statins in pregnancy. Any drug which is absolutely contraindicated in pregnancy, it comes under pregnancy classification or category of category X drug. The reason is very simple, beta. Do you want to inhibit cholesterol synthesis in fetus? All cells are made up of cholesterol. So we never give statins in pregnancy. Similarly, statins are absolutely contraindicated in children because children are growing. So if the child is less than 12 years of age, statins are contraindicated because statins, they can cause stunting. Growth of the child will be inhibited and there is more risk of myopathy in children. But there is one statin which can be given in an age group of 8 to 12 years. In 8 to 12 years, we can give pravastatin. So we can write like pravastatin is contraindicated in children less than 8 years of age. The reason was that we tried pravastatin in children above 8 years of age, it was found to be safe. So it is the only approved statin in children between 8 to 12 years of age. Now after statin, let's talk about the second hypolipidemic drug. They are known as resins. Now resins, they are also known as bile acid binders. It is also known as bile acid sequestrant. Now what does it mean? We all know that liver secretes bile and bile contains cholesterol. Normally this bile comes to intestine and the bile which comes into the intestine again gets reabsorbed from intestine back to the liver. This reabsorption of bile from intestine back to the liver, we call it as enterohepatic reabsorption of bile. So can we say through this bile, cholesterol again goes back to the liver? Absolutely fine. Now what are resins? See the name again. Bile acid binders or bile acid sequestrant. When we give resins, they bind to bile and this bile will not be reabsorbed. This bile will be sequestered in feces or it will be excreted in feces. So in simple word, can we say that bile acid binders, they inhibit enterohepatic reabsorption of bile. Statins were inhibiting cholesterol synthesis in liver. Resins are inhibiting the absorption of bile. Bile contains cholesterol. Can we say that now liver will not get cholesterol from the bile? What liver will say? Sir, I need cholesterol at any cost. So what will happen? Slowly and slowly on liver, LDL receptors will increase just like statin and liver will now take cholesterol from the blood and blood LDL level will reduce. So same like statins, they also increase LDL level in the blood. So let's understand in a more simplified manner. Suppose this is the green color bile which is circulating in your intestine. So resins, they are inhibiting this enterohepatic reabsorption of bile. So again, the LDL receptors on liver will increase. And we know that if there is increase in LDL receptors on the liver, liver will take LDL from the blood and the blood LDL level will fall. So let's see what are the drugs we have in resins. In resins, the drugs, they will start with the word chol, cholestyramine, cholestypol and cholesevolum. So you can easily pronounce chol word will come, that means they reduce cholesterol or blood LDL level. Now the first two drugs, cholestyramine and cholestypol, sir, why they are known as resins? Resins means any sticky material. So just imagine when you take this drug, will you able to swallow it easily? The answer is no. So these drugs are available as a powder form. So we have converted into powder form, put the powder and drink with, suddenly engulf this drug with plenty of water. Now this becomes a very difficult task for the patient. That is why we made cholesevolum. Cholesevolum recently has been approved as in a tablet form, which is now easy for the patient to take it. So where do we use resins? So resins are also reducing blood LDL levels. But we already know that statins are the best drug to reduce LDL level. Then what is the place of resins? We discussed statins are not given in pregnancy. Resins, they only act on intestine. They are not absorbed into the blood. So resins are absolutely safe in pregnancy. So raisins are the drug of choice for hypercholesteremia or increase in cholesterol level. If occurs in pregnancy, then we give raisins, because in this condition statins are absolutely contraindicated. So this is the main place of raisins. Apart from this, raisins, they are given as an add-on drug to statins to further reduce blood LDL level. Now, what are the side effects of raisins? Very logical. If the bile will not get reabsorbed, all the bile will be excreted in feces. And with bile, all the fat-soluble vitamins which require bile for their absorption, they will also get excreted in feces. So, raisins, they can lead to malabsorption of all fat-soluble vitamins. So, there will be deficiency of all fat-soluble vitamins with raisins. One of the reasons we rarely use these drugs nowadays. Now, apart from this, there are certain drugs which require bile for their absorption. Let's write the names of 3 drugs DPT. First is digoxin, drug for heart failure, propranolol, beta blocker, and thyroxine hormone. A patient of hypothyroid might be taking thyroxine hormone. So, deficiency or decreased absorption of these drugs can occur with raisins. So, they can show lot of drug interaction, rarely used drug nowadays. Now, we use statins more. Let's talk about the third very important class of drug, that is fibrates. So, fibrates, they are known as lipoprotein lipase activators. They are known as lipoprotein lipase activator. Recall, we discussed that on our blood vessel, endothelial cells, there is a lipoprotein lipase enzyme. So, these fibrates, what they do, inside the endothelial cells nucleus, there is a receptor known as PPAR alpha receptors. Fibrates, they come and activate this receptor. So, PPAR stands for peroxisomal proliferator activating receptor. So, you can see receptor word is coming. So, it's a kind of a nuclear receptor present inside the nucleus of endothelial cell. Fibrate, they activate this receptor, and when this receptor becomes activated, on the surface of endothelial cells, lipoprotein lipase enzyme, it comes. So, this receptor is responsible for synthesis of lipoprotein lipase enzyme. And we discussed just that lipoprotein lipase enzyme inside the blood, it removes triglyceride. It removes triglyceride from the blood. So, the main action of fibrate is to remove triglyceride from the blood. So, these fibrates, they are hence also known as PPAR alpha agonist. Because they stimulate PPAR alpha receptor, they increase the production of which enzyme? They increase the production of lipoprotein lipase enzyme. So, let's understand in a more simple manner. So, fibrates, they come inside the endothelial cell. They activate PPAR alpha receptors, which increase the production of lipoprotein lipase enzyme, which removes triglyceride from the blood. So, what are the different drugs we have in fibrate group? We can easily remember clofibrate. Fibrate word is coming. Fenofibrate, bezafibrate, we can easily remember, and gemfibrozil, some fibro word is coming. The first drug which we made was clofibrate. Now, this clofibrate, it has been banned now. The reason was clofibrate was reducing triglyceride level in the blood, that we know, but it was increasing LDL level. And LDL contains cholesterol. Cholesterol can lead to atherosclerosis. Atherosclerosis can lead to MI. So because of the risk of myocardial infarction, it got banned. So now available drugs in the market are fenofibrate, bezafibrate and gemfibrozil. Now let's see which drug is the best drug to be used. Let's understand. So fenofibrate, it has no CYP inhibiting action, and gemfibrozil has CYP3A4 inhibiting action. It's a CYP3A4 inhibitor. So can you tell me which drug combined with statins can increase the risk of myopathy? Statins are degraded by CYP3A4. So gemfibrozil increase the risk of myopathy of statins. So we should combine with statin gemfibrozil? The answer is no. So which drug is most commonly combined with statins? That is fenofibrate. So most commonly in the market you will find fenofibrate with some statin like rosuvastatin or atorvastatin. So let's talk about where fibrates are used. Fibrates are the drug of choice for hypertriglyceridemia. If you want to reduce triglyceride level, then we give fibrate. So if triglycerides levels are more than 350 milligram per deciliter, then we start fibrate. So what are the causes of increase in triglyceride level? The most important cause is alcohol. If you drink alcohol, the blood triglyceride level increases, and you must have learnt that alcohol damages pancreas because of one of the reason, increase in triglyceride level. Diabetes mellitus also increases triglyceride level. And certain genetic causes of increase in triglyceride level is, that is familial dysbeta lipoproteinemia. So in this condition, the triglyceride levels are genetically increased, and everywhere the drug of choice is fibrate. Now what are the main side effects of fibrate? The first side effect is same like statins, they causes myopathy and they produce gallstones. Because they reduce gallbladder motility, slowly and slowly cholesterol becomes deposited. Now let's talk about the fourth drug, that is niacin. Niacin is also known as nicotinic acid, and niacin is also known as vitamin B3. Remember, when we take niacin as a vitamin, we require very low dose of niacin per day, that is in some micrograms. But when you are using niacin as a hypolipidemic drug, it requires very high dose. So in a very high dose of 2 to 6 grams, niacin has hypolipidemic effect. So its hypolipidemic effect comes at a very high dose, not at a vitamin wali dose. So in very high dose, niacin acts on liver and niacin acts on adipose tissue. So it has two organs where it will act. It will act on fat cells or adipose tissue. On liver, niacin directly reduce triglyceride synthesis, and on adipose tissue it inhibit breakdown of fat, that is lipolysis. Because if there is breakdown of fat, it will lead to triglyceride production. So these are the two reasons why niacins reduce triglyceride production. Second point, in liver, niacin also reduce a very important lipid known as lipoprotein A synthesis. Lipoprotein A is a defective form of LDL, and it is only produced by the liver when there is atherosclerosis. Lipoprotein A is a marker of atherosclerosis, and it is reduced by which hypolipidemic drug? that is niacin. And niacin is the drug which also increases HDL levels. And among all drugs, maximum increase in HDL level is by niacin. So it has various function. It has direct action on liver and adipose tissue. So if niacin has such a good effect, why we don't use niacin very commonly? Because I'm going to tell you that in such a high dose, niacin among all hypolipidemic drug, it is the most toxic drug. So it is never used as a first line drug. Niacin is only used as a add-on drug. So it is only used as an add-on drug to statins. Why? And it is mainly given to increase HDL levels. So if you want to increase HDL level, then we give niacin as an add-on drug to statins. Otherwise, we never start in our patient niacin because niacin is the most toxic drug we have. In such a high dose, it is a very dangerous drug. So let's see the adverse effect of niacin. So the first side effect or adverse effect of niacin is flushing. And flushing is the most common side effect of niacin. Why this flushing occurs? Because niacin increase the production of prostaglandin D2. Prostaglandin D2 is a cutaneous vasodilator. It means it dilates blood vessel on skin, which can lead to flushing, which is the most common side effect. So the question comes, how to treat it? Treatment is very simple. We can give aspirin. Aspirin, by inhibiting COX enzyme, decrease the production of prostaglandins. So niacin induced flushing, give aspirin. But there is a new drug which we have made, laropiprant. Laropiprant. See the name, PR means prostaglandin, ANT means antagonist. Antagonist means blocker. Laropiprant is a PGD2 antagonist. It blocks the receptor of prostaglandin D2, a new drug for treating niacin-induced flushing. Now let's see the other side effect of niacin. Niacin is hepatotoxic drug. And this is the most hepatotoxic drug among all hypolipidemic drugs. That is why we rarely use niacin. Niacin also causes increase in blood uric acid level. It causes hyperuricemia. Increase in uric acid level can lead to gout. That is why niacin is bad for gout. And niacin causes hyperpigmentation. The reason is very simple. With the help of niacin, melanin pigment is produced, which leads to hyperpigmentation. So these are the adverse effects of niacin. Now let's talk about which hypolipidemic drug affect blood uric acid level. So uric acid levels is reduced by which hypolipidemic drug? Statins. Statins, they reduce blood uric acid level. We discussed pleiotropic effect and fenofibrate. Fenofibrate also reduce blood uric acid level. Because of this reason, these drugs are good for gout. And which drug increases blood uric acid level? The answer is niacin. That is why niacin is a bad drug for gout. It itself can precipitate an attack of gout. This is a recently asked question. Now, which hypolipidemic drug affect diabetes mellitus? Remember, statins and niacin. These two hypolipidemic drugs, they increase the risk of insulin resistance. And you know that if there is insulin resistance, there will be hyperglycemia. Because of hyperglycemia, they themselves aggravate diabetes mellitus. So statins and niacin, these drugs are bad for diabetes mellitus. But remember one point, even if they are bad for diabetes mellitus, statins are still given in diabetes mellitus. The reason is the benefit of using statins is more as compared to the risk of diabetes. Because in diabetes, the patient dies because of MI and stroke. Statins, they reduce the risk of MI and stroke, which is more important for us as compared to hyperglycemia. So still they are given in diabetes mellitus, although they cause hyperglycemia. So these are the drugs. Let's make a summary that when you give these 4 drugs, statin, resins, fibrate and niacin, how they will affect lipid profile of a patient. So when we do lipid profile, we check LDL cholesterol, we check total triglyceride, we check HDL levels. Now statins, they decrease LDL levels. Resins, they also decrease LDL level. Fibrates can also decrease LDL level. Niacin can also decrease cholesterol level. But which drug causes maximum decrease in blood cholesterol or LDL level? The answer is statins. Statins, they can reduce blood LDL by more than 50%. That is why statins are the drug of choice for hypercholesteremia. So if hypercholesteremia comes, the drug of choice is statin. What about triglyceride level? Statins, they can reduce triglyceride level. Resins, they can increase triglyceride level. Hence, they are bad. Fibrates, they also decrease triglyceride level. And niacin also decrease triglyceride level. But which drug causes maximum decrease in triglyceride level? The answer is fibrates. Fibrates, they can reduce triglyceride by more than 50%. What about niacin? Some 40 to 50%. Okay. What about HDL? Remember, we have to increase HDL. HDL is a good lipid. High density lipoprotein is a good lipid. Statins, they can increase HDL level. Resins have no effect on HDL level. Fibrates, HDL, HDL. But maximum increase in HDL level is by niacin. So what is the use of resins now? Resins are the drug of choice. Only one use, pregnancy. What about fibrate? Fibrates are the drug of choice because they are decreasing triglyceride maximum. They are given for hypertriglyceridemia if triglyceride are more than 350. With niacin, we will write niacin is the drug of choice if you want to increase HDL level, but niacin is the only molecule we have which also decrease lipoprotein A levels. Which drug can reduce lipoprotein A levels? That is niacin. So keeping this thing in mind, let's imagine a patient of abnormal lipid profile comes to you. Which drug you will start first? So we basically check HDL, LDL cholesterol, triglyceride and total cholesterol. So what is the normal range? Normal range, HDL should be more than 50, LDL should be less than 100, triglyceride should be less than 150 and cholesterol should be less than 200 milligram per deciliter. These are the normal range. So imagine patient is having abnormal lipid profile. That means patient HDL level is less than 50, LDL is more than 100, triglyceride is more than 150 and cholesterol is more than 200. In this case, we will start to give a drug, and drug of choice for all cases, the first drug you will start is statins. So statins are the drug of choice. In all cases, the first drug to be started is statin, rosuvastatin and atorvastatin. But if you want to further increase HDL level, add niacin. So why we give niacin? to further increase HDL level. If statins cannot increase HDL, add niacin. Second point, if the triglyceride level is more than 350, in this case, add fibrates. In this case, add fibrates. So even if the patient is having raised triglyceride level, we first start with statins. Okay? And if the triglyceride are not controlled by statins and if it is more than 350, then we add fibrate, because more than 350, there is sudden increase in the risk of acute pancreatitis. Now let's talk about certain new hypolipidemic drugs. So we can remember a mnemonic. So the first drug is ezetimibe. Then a very important class of a drug, PCSK9 inhibitor, lomitapide, omega-3 fatty acid and bempedoic acid. These are the new hypolipidemic drugs. So let's start with the first drug, that is ezetimibe. Ezetimibe, what is the mechanism of action? Ezetimibe inhibit one transporter. The name of the transporter is NPC1L1 transporter. Now this transporter is present in intestine, and this transporter is responsible for cholesterol absorption from intestine. So if you inhibit this transporter, ezetimibe inhibit cholesterol absorption from intestine. So dietary cholesterol will not come into lymph, into chylomicron. So what is the use of ezetimibe? Ezetimibe, what is the effect? If cholesterol level is reduced, finally LDL level will be reduced. So ezetimibe we made to reduce blood LDL level, and ezetimibe is given as an add-on drug to statins. Right now it is given as an add-on drug to statins to reduce LDL level further. Next drug, a very important class of drug for you, many times asked, that is PCSK9 inhibitor. Now sir, what is this PCSK9 enzyme? In our liver, we have PCSK9 enzyme, and the function of this PCSK9 enzyme is to degrade LDL receptors on liver. So if you give PCSK9 inhibitors, LDL receptors will not get degraded, and on liver, LDL receptors will increase. And this LDL receptors will take LDL from the blood, which will reduce blood LDL levels. So hence, PCSK9 inhibitors, in simple word, they increase LDL receptors on liver, because PCSK9 enzyme is normally responsible for degradation of LDL receptors on liver. So if you inhibit this PCSK9, LDL receptors will increase in the liver. So let's see what are the drugs we have. So among PCSK9 inhibitor, the first drug we have is evolocumab, many times asked, and alirocumab. You can see MAB word is coming. MAB stands for monoclonal antibody. So these are the antibody against PCSK9. So if you inhibit this PCSK9, these drugs, they increase LDL receptors on liver. So how we can remember the names of these two monoclonal antibody, evolocumab and alirocumab? You can see LOC. LOC word is coming. These monoclonal antibody will have LOC word in them. How we can remember? LO means lowering of cholesterol. They reduce cholesterol in the blood. Because they increase LDL receptors on the liver, it reduces blood LDL levels. Now, why these drugs are very frequently asked from you people? The reason is, these drugs, they are even more effective effective than statins. So till now I have told you that statins, they reduce LDL maximum in the blood, but these drugs can even reduce LDL even more than statin. So these drugs are given in resistant cases of statin. If statins cannot reduce adequately LDL level, then give this drug. In India, we give them in resistant cases of statin because antibodies are very costly drug. If you see American guidelines, these drugs are even started first or before statin, because if a people can afford, then these drugs are even more effective than statin. A new drug recently got approved, a PCSK9 inhibitor, is inclisiran. Inclisiran also inhibit PCSK9. Now it is not an antibody. You can see in inclisiran, siRAN word is coming. So it is siRNA. siRNA means silencing RNA. So silencing RNA means it will reduce the production of RNA or protein of PCSK9 in liver. So it's silencing RNA, it reduces the production. Now the next drug we have is lomitapide. In lomitapide you can see MTP word is coming. So lomitapide is an MTP inhibitor. MTP stands for microsomal triglyceride transfer protein. Now this MTP or microsomal triglyceride transfer protein, this protein is responsible for VLDL production in liver. So if you give lomitapide by inhibiting MTP protein in liver, it decreases VLDL production in liver and VLDL levels will reduce in the blood. So this drug is given to reduce VLDL levels. Now, do we have any natural molecules which can reduce VLDL production in liver by inhibiting MTP protein? The answer is yes. One more drug is there, that is omega-3 fatty acids. Remember, omega-3 fatty acids, they are a very rich source of fatty acids which is present in fish. That is why eating fish is good for heart, because omega-3 fatty acid or fish decrease the production of VLDL by inhibiting MTP protein. Lomitapide also inhibit MTP protein. So we have made omega-3 fatty acid as a drug. They also decrease VLDL levels in the blood. So these drugs are Icosa pentaenoic acid. And another omega-3 fatty acid is docosa hexaenoic acid. Icosa pentaenoic acid is also known in short form as icosapent. Short form is icosapent. So omega-3 fatty acid is good for heart. Next, a new drug is bempedoic acid. So beta, we just discussed that cholesterol is produced from HMG-CoA reductase, from HMG-CoA, and the enzyme is HMG-CoA reductase enzyme. But this HMG-CoA, it is produced from ATP citrate with the help of ATP citrate lyase enzyme. Now, which drug was inhibiting HMG-CoA reductase and decreasing the production of cholesterol? Those drugs were statins. Now we have a new drug, bempedoic acid. Bempedoic acid inhibit ATP citrate lyase. So this is a new drug which is given as an add-on drug to statin to decrease cholesterol production, and cholesterol is the main component of LDL. A new drug, add-on drug to statin, is bempedoic acid. It also decreases cholesterol production by inhibiting ATP citrate lyase. Now let's talk about some rare new drugs. Another new drug is mepomersane. Remember, any drug which ends with the word ursane, ursane is RNA antisense strand. That means we have made opposite copy of RNA. So don't you think if you have made RNA antisense strand, it will inhibit RNA transcription of some normal RNA? Agreed? So let's talk that normal RNA as ApoB100. So there must be some RNA of ApoB100 which is making some defective type of LDL. So if there is some defective type of ApoB100 which is a part of LDL, its transcription is reduced by antisense strand of RNA. The drug name is Mepomersen. In which condition there is defective production of ApoB100? One genetic condition known as familial homozygous hypercholesteremia. So in this genetic condition, familial homozygous hypercholesteremia, there is some defective production of LDL because there is some defective protein on LDL, ApoB100. So ApoB100 is made from translation of RNA. We made an antisense strand of this RNA, Mepomersen. It will bind to normal RNA and this ApoB100 will not be produced. So a drug approved for a rare genetic condition when there is increase in LDL level and increase in cholesterol levels, familial homozygous hypercholesteremia. Now last drug we have is N-acetrapib, torcetrapib. You can see some CETP word is coming in both of them. So these drugs are, as the name CETP is coming, they are CETP inhibitor. CETP stands for cholesterol ester transfer protein. Now where this CETP is present, the function of this CETP is to take cholesterol from HDL and donate this cholesterol back to LDL. We know that HDL takes cholesterol from body cells and this HDL donates its or transfer its cholesterol back to LDL and this LDL is removed by liver or uptaken by the liver. This is the function of CETP, cholesterol ester transfer protein. So when you give a drug N-acetrapib and torcetrapib, they inhibit this transfer of cholesterol from HDL to LDL. So can we say if we inhibit this step, what will happen? Slowly and slowly, HDL level will be increased in the body. So these drugs were made because they were increasing HDL level in the body. So sir, this is a very good thing. We increase HDL level, but just think for a second. Do you think now liver will be able to remove LDL from the blood? The answer is no. Now liver will not be able to remove LDL from the blood and LDL can lead to MI and stroke. That is why these drugs, they were made with good intention to increase HDL level, but now liver will not able to remove LDL from the blood. These drugs, they got banned because they were increasing the risk of MI and stroke. So these drugs got banned. So this is all about hypolipidemic drug. Let's make a summary now. So let's make a summary of first 4 hypolipidemic drug. Statins, what is their mechanism of action? They are HMG-CoA reductase inhibitor. Why we made statin? We mainly made statin to reduce blood LDL level. Statins are the drug of choice for hypercholesteremia. And what is the adverse effect of statin? Statins are hepatotoxic and statins, they produce myopathy. Then we have raisins, cholestyramine, cholestyramine. They are bile acid sequestrant. That means they reduce enterohepatic reabsorption of bile. So why these drugs were made? Again to decrease LDL level. But remember, statins, they reduce maximum LDL. Where these drugs are used? These drugs are the drug of choice in pregnancy because statins, they are not given in pregnancy. What is their side effect? They can cause malabsorption, which can lead to deficiency of fat soluble vitamins. Then we have fibrates, clofibrate, fenofibrate, gemfibrozil. These drugs are PPAR alpha agonist. By increasing PPAR alpha activity, they increase the amount of lipoprotein lipase enzyme. And these drugs, they are made to decrease triglyceride maximum. Where these drugs are used, they are given for the treatment of hypertriglyceridemia if triglycerides are more than 350 milligram per deciliter. But the first drug you will start is statin. Now, what are their side effects? Again, they can cause myopathy like statins and they can cause gallstones. Then we have vitamin B3, niacin, also known as nicotinic acid. This drug inhibit triglyceride levels, triglyceride synthesis in liver. It inhibits lipolysis in fat. It decreases lipoprotein A levels and increases HDL levels. So it is mainly given with other drugs to increase HDL level maximum, and it is the only drug which reduces lipoprotein A level. So it is given as a drug of choice to increase HDL as an add-on drug to statins. So it is the most toxic drug. It causes flushing. It can cause hepatotoxicity and it can increase the risk of gout because it increases blood uric acid level. What about new drug? Ezetimibe, which was reducing cholesterol absorption from intestine by inhibiting a transporter, NPC1L1 transporter. PCSK9 inhibitor, I have told you, identify the word LOC, lowering of cholesterol. So the drugs was evolocumab and alirocumab. Evolocumab, alirocumab. Lomitapide, MTP word is coming. It is an MTP inhibitor, microsomal triglyceride transfer protein, which decreases VLDL production. Omega-3 fatty acid also reduce VLDL production. Bempedoic acid, a new drug, inhibit which enzyme? One enzyme which was acting before statins were acting, ATP citrate lyase enzyme. N-acetrapib and torcetrapib, you can see the CETP word is coming. They are CETP inhibitor, cholesterol ester transfer protein, but these drugs, they got banned because they were increasing HDL, but liver cannot take LDL. LDL high levels can lead to MI. Now let's talk about certain MCQs. So which of the following statins have the most prolonged duration of action? In other words, which of the following is the longest acting statin? So I have told you the longest acting statin is Rosuva, followed by Atorva. So you will go with the answer Rosuvastatin. It has become the most commonly prescribed statin at today's time. A medication most likely responsible for precipitating patient symptoms of muscle pain, fatigue, dark urine. Can you tell me why dark urine? Cola colored urine. Elevated serum creatinine kinase level, CPK level. So can you tell me the patient is suffering from myopathy or rhabdomyolysis? Agreed? So which drug? Rhabdomyolysis we know is seen with statins. Statins are degraded by CYP3A4 enzyme. Okay. And which of the following drug inhibits CYP enzyme? That is erythromycin. We discussed erythromycin is a CYP inhibitor which increase the blood levels of statin, which can lead to myopathy with statins. A 45-year-old diabetes mellitus type 2 patient comes with the symptoms of episodic chest pain, shortness of breath, easy fatigue, and elevated cholesterol and triglyceride level. So can we say patient is suffering might be from angina or MI, and his cholesterol and triglyceride levels are increased? Which of the following vitamin can provide benefit? So can you tell me which vitamin reduces blood lipid levels? Yes, that is vitamin B3, nicotinic acid is the answer. Next question, which drug have the maximum capacity to reduce lower serum triglyceride level in the patient of hypertriglyceridemia? Remember, fibrates, they have the maximum capacity to reduce triglyceride level. Statins have the maximum capacity to reduce LDL levels. And niacin has the maximum capacity to increase HDL levels. Okay? Ezetimibe, new drug, given along with statin. A 48-year-old female presents to OPD with the complaints of chest pain, palpitation, swelling in her legs, shortness of breath. Might be some heart disease? Yes. The vitals are in normal range. Physical examination, pedal edema. That means the heart is unable to pump sufficient amount of blood. That means the patient is going into heart failure. She is a known case of dyslipidemia and she is currently under the treatment with gemfibrozil. Fibrozil means it's a fibrate. Keeping in mind the mechanism of action of this drug acts on. So it is a fibrate, and we discussed fibrate, they increase lipoprotein lipase enzyme by activating PPAR alpha receptor on endothelial cell. HMG co-reductase inhibitor is statins. Okay, statins, they reduce cholesterol synthesis in liver. Which drug reduces cholesterol absorption from intestine? Ezetimibe. Now, which of the following anti-hyperlipidemic drug exerts its effect through inhibition of PCSK9? So, PCSK9 inhibitor, I have told you, a mnemonic, a word, LOC you have to identify, lowering of cholesterol. So, which monoclonal antibody you can think is having LOC word in it? That is LOC, alirocumab is the answer. And another drug which we have discussed is evolocumab. They are PCSK9 inhibitor, very frequently asked MCQ. So this finishes our hypolipidemic drug. Best wishes. Thank you very much.